Hello, class. We are going to start chapter 6, which is all about the skeletal system. We're going to cover the majority of the actual bones and their parts in lab, and we'll cover the physiology piece here in our online lecture area. This, just so you know, there is overlap in what you need to know for lab and lecture. So as we're covering the bones and the specific parts of the bones in lab, you may see test and quiz questions based on what you learned about in lab. So don't think just because you're learning it in lab, you're not going to be tested on it in a lecture exam. You may. For the most part, I try not to do diagrams and that type of a thing on my quizzes, but there may be a diagram on your exams. That's not a hint or anything. I'm just letting you know that I may put that on there for you to label or describe or whatever. So just be aware of that. We're getting into chapter 6. Here it is. Just needed to find my screen. Alrighty. So we're talking about skeletal system, the bones, right? There's 206 bones in the adult body. There's more in a fetal body or an infant body, and that's because the bones haven't fused together. Typically, we divide the body into axial, which is our thorax, head, vertebral column, and appendicular. So appendicular, of course, are the appendages. We're including cartilages and ligaments and other connective tissues in the skeletal system as well. Here's axial, appendicular. Let's talk about functions first. First function is support. Obviously, it's there for support for our whole body. It provides a framework for attachment of all of our soft tissues, some organs, etc. It's also there for storage of minerals and storage of lipids. Did you know that adipose tissue can be stored inside your bones? Yep. There's also concentrations of calcium, phosphate, magnesium, etc. in your bones. And so your bones act as a reservoir for this. If your blood calcium gets too low, then calcium is going to be taken from your bones and put into your blood. Calcium is the most abundant mineral in the body. We need it almost for every body system. You will hear calcium being used. And when you think calcium, think bones, but also think diet. You have to bring it in your diet. We'll get into that more later. You need your skeletal system for red blood cell production. Most of you know, or maybe you're aware of, the fact that your red bone marrow makes blood cells. That is inside of your bones. So without your bones, you wouldn't have that special area for blood cells to be made. Bones are also there for protection. Your skeletal muscles, or your skeleton, will protect all of your vital organs, like your skull protects your brain. Your sternum and rib cage protect your heart and your lungs. Your vertebral column protects your spinal cord. So very important for protection. They're also there for leverage. Leverage in terms of movement. Your skeletal muscles attach to your skeleton to provide movement. They act as levers for overall movement. This is just a summary from your book. You can pause the video, go back and answer these 3 questions. Let's talk about how bones are classified. They're typically classified on shape and markings. They can be flat, sutural, long, irregular, sesamoid, or short. Let's take a look at flat bones first. Flat bones are typically thin, have parallel surfaces. This would be something like our ribs, our scapula, and our cranial bones. They almost sometimes look like cardboard, where they'll have a flat area, and then some junk in the middle. Right, kind of like corrugated cardboard. They usually are there for protection, and they also provide an area for skeletal muscles to attach. Sutural bones, which are sometimes called Wormian bones, depending on your book source, they're just irregular bones that can be formed in between your cranial bones, and the number, shape, and size vary. When babies are born, their heads are not fused, and sometimes little pieces of the larger bones break off or just form little sutures along the way as they're all trying to join together. And those little tiny guys are called sutural bones. Some people have 10 of them. Some people have 200 of them. It's just a genetic variance. Long bones are probably what you think of when you think of bones. These are typically our appendicular bones, like our arms and leg bones. The femur is the long bone in the thigh. That's our longest, heaviest bone in the body. Irregular bones are usually short, flat, They're kind of rigid. These would be like our vertebrae, our pelvis, our facial bones. They just have an irregular shape, so we throw them into this hodgepodge category. Sesamoid bones usually develop inside tendons. These would be bones of the hands, the knee, and the feet. There's an actual variation in their location and number in some cases, but they're typically very small and flat. Look like a sesame seed, hence sesamoid. And the short bones would be like the bones of the wrists and bones of the ankles. They're usually small and boxy. Here's a good overview of what they are and where they are. Let's talk about surface markings. These are elevations and projections. They're depressions and grooves. They all have a purpose. A bone doesn't have a lump or a bump or a hole just because. It has a lump or a bump or a hole because it's important. It's either a spot for a tendon to attach or a ligament to attach, or it is a location for a blood vessel to enter, or maybe a nerve to enter. So some general surface markings, and I'm going to breeze through this very, very quickly here because we're going to cover it in lab. But there's a head, a diaphysis, and a neck. The diaphysis is the long portion of a long bone or the shaft. The head is usually proximal. There's also things like a process, a tubercle, a tuberosity, a trochlea. These are all just projections or elevations, and they, again, all provide attachments for ligaments and tendons. Do I expect you to memorize this list? Absolutely not. You will have to memorize them in context. In other words, you will have to know the acromial process or the greater tubercle of the humerus. And so when I say that, you'll know exactly what it is. Don't memorize this list in isolation. That's kind of a waste of time. Same thing with these. More elevations and projections, trochanters and facets and crests and lines and spines and ramus. These are all just different pieces of specific bones, and as we go through our specific bones, you will learn them in context. So cranial canal or meatus, those are just little holes or a tunnel. A sinus is a chamber. Foramen is a large rounded passageway. A fissure is a big gap or a space. A sulcus is a groove. A fossa is a depression or a flat space. And here you can see some of these features on our skull. Here you can see some of the features on the humerus. Here you can see some of the features on the femur. And here you can see some of the features on the pelvis. You can pause the video, go back, and review. Let's talk about some features of a long bone. They have an epiphysis. The epiphysis is the end of the long bone. This is usually made of spongy bone. Spongy bone is sometimes called cancellous bone or trabecular bone. It usually has a network of struts and plates to reinforce it from different directions. The outer covering of the epiphysis is compact bone, and compact bone is very organized and very strong. There's also articular cartilage that's on the epiphysis. The articular cartilage covers the end of the bone so that it's protecting it from friction against other bones. It's avascular, as all cartilage is, so it doesn't have any blood supply going to it. The metaphysis is connecting the epiphysis to the diaphysis. The diaphysis is the shaft. The metaphysis is just the kind of mid-line point between the epiphysis and the diaphysis. The diaphysis is the long tubular portion, typically has a thick wall of compact bone, and then there's a medullary cavity or a marrow cavity that's filled with marrow. It can be filled with red marrow or yellow marrow. The yellow marrow is the adipose tissue. It's very important energy reserve, and the red marrow is where our red blood cells are created. Here's looking at a nice cross-section of the femur. You have that spongy bone on the side, spongy bone lining the medullary cavity, spongy bone at the epiphysis, and then the compact bone, which is mostly where the diaphysis is and the outer covering of the epiphyses. Again, the articular cartilage would be covering the ends of the long bone as well. Let's talk about how these long bones are maintained. They are vascular, whereas cartilage is avascular and does not have a blood supply. Bones are vascular. They have a nutrient artery and nutrient vein. Usually there's just one per bone. Some long bones have several, like your femur. There's a nutrient foramen, which is the little tunnel where these veins and arteries can get in. And there's also the job of this nutrient artery and nutrient vein is to supply the osteons with the nutrients that they need to maintain the bone. The metaphyseal artery and the metaphyseal vein carry the blood to and from the metaphysis and connect the epiphyseal arteries and veins together. So the metaphysis is that special area between the diaphysis and epiphysis, and that's where growing will occur, and so that has its own special blood supply as well. Here you see them. This is the nutrient artery, nutrient vein supplying the diaphysis, and then the metaphyseal artery and our metaphyseal vein going into the metaphysis, supplying the epiphysis as well. So the periosteum is the outer covering of our bones, kind of like the bone blanket. Remember, it's made of dense, irregular connective tissue. This is where smaller blood vessels are found. The blood vessels in this periosteum are also supplying the underlying superficial osteons of the bone. There's also lymphatic vessels in this area and sensory nerve fibers as well. So here's the periosteum, the outer covering, and then this is the compact bone. So the vessels of the periosteum kind of dip into the bone tissue as well. You can pause the video here, go back and answer the questions. Let's talk about the types of bone cells. You have osteocytes. These are the majority of bone cells. These are mature bone cells that can no longer divide. They basically are there to maintain the protein, maintain the mineral content, like the calcium content of the bones. And the main protein of bones, if you recall, is collagen, our collagen protein fibers. So they're maintaining the surrounding matrix. They can dissolve the matrix to release the calcium. They can also help to rebuild the matrix and deposit the calcium. They live in little lacuna or pockets. I like to think of them as little nests, but the lacuna are living kind of nestled within the osteon site. They're interconnected by canaliculi. There's also osteoblasts. Osteoblasts are building. They're responsible for osteogenesis or ossification. So they are basically beginning to produce that calcified bone substance. They assist in putting the calcium salts into the bone tissue itself. They will eventually become osteocytes when they're all grown up, when they are finally surrounded by the ossified tissue itself. There's osteoprogenitor cells or osteogenic cells, same thing. These are the stem cells that will produce the osteoblasts and osteocytes, because once osteoblasts grow up, they become osteocytes. They're very important in fracture repair. They're typically located on the inner lining of the periosteum, the lining of the endosteum, and the passageways where the blood vessels are. Osteoclasts are the breaking cells. These are the ones that will remove and remodel the bone. They're huge cells. They are derived from the same stem cells as macrophages, so they're kind of more related to immune cells than bone cells. They're basically releasing acids and enzymes to dissolve the bone matrix. So these are working antagonistically to our osteoblasts. They do a process called osteolysis. So if your blood calcium levels drop, these osteoclasts are going to activate to release some calcium from the bones into the blood. Here you see them all in action. Here's the osteons. Osteons are these little tree trunk-like structures. You can see the rings. The rings are called lamella. The lamella are just the, again, they're just the little kind of areas where the osteocytes are living. And the osteocytes, here you see one living in a lacuna. The osteocytes is this little gray thing. The lacuna is this whole nest or cavity. It's connected by these canaliculi to other osteocytes, and they exchange nutrients and waste products. And that's also how the nutrient artery and vein products, like all of the blood and everything, gets out to those osteocytes through the canaliculi. The osteogenic cells are special stem cells. They typically line the medullary cavity in the endosteum. The endosteum is the inner lining or inner covering, and then osteoclasts are in there as well, typically in with the spongy bone and endosteum. And again, they're very, very big cells that are there dissolving the bone matrix. So let's talk about that bone matrix. Bone matrix is made of mostly collagen fibers. About a third of bone is just collagen. And then calcium phosphate is the other 2/3. The calcium phosphate will interact with something called calcium hydroxide to form a crystal called hydroxyapatite. This salt basically will incorporate other salts like magnesium and fluoride basically to provide extra strength for the bone. So the calcium phosphate becomes harder and more durable with the addition of these special salts. As you see here, much without the salts, it can be fairly pliable, bendy, as opposed to being more rigid. So you can pause the video here, go back and answer these 3 questions. Let's talk about compact bone. As I mentioned, it's called an osteon, the functional units. That's that tree trunk structure. It's organized by concentric lamella, or the little rings of the tree, as we saw where those osteons lived, and there's one central canal in the middle. The osteocytes live in the lacuna, and they are arranged in these lamella, or these little concentric circles, and the central canal is in the middle of the osteon. The canaliculi will connect the lacuna with each other and the central canal for exchange of nutrients and waste, and it's strong and held together, usually along the length of it. That's where this strength comes from, not the width. So it's not as strong this way, it's more strong this way, and that makes sense because of gravity, right? So here's just showing you that nutrient artery, nutrient vein in that central canal, and then the lamella coming out. Basically, those are just the channels. The canaliculi are these little like vessels connecting that central area to the outer lacuna where the osteocytes live. Here's an actual picture, and you saw these in lab the other week, where you have that central canal, the concentric lamella, and the osteons living, or the osteocytes rather, living in these little lacuna. You can even see the canaliculi radiating out from that central canal. So let's talk about how long bones are organized. They have a periosteum, which is the outermost layer. This is that connective tissue covering. The compact bone is the outer tissue layer of bone. It's made of circumferential lamella on the outer surfaces. The interstitial lamella will fill the spaces in between the osteons, and the osteons themselves with those central canals and the perforating canals. Spongy bone is the innermost layer of our long bones. So here you see spongy bone, our osteons in the interstitial lamella and the circumferential lamella inside, and the outermost covering is the periosteum. Spongy bone is located where bones are typically not heavily stressed, so the lamella form struts or plates, and we call those trabeculae. They basically form this kind of stalactite, stalagmite-like network inside of the bones. Basically reduces the weight of the bone. If the entire bone was made of compact bone, it would be very, very heavy and hard to move. There's no blood vessels in the matrix of spongy bone, so the nutrients reach the osteons through the canaliculi that open into the open surfaces. The red bone marrow is found between the trabeculae. Here you can see a real picture of the trabeculae. Again, just looks kind of like bubbly bone as compared to this compact bone, which is very, very dense. There it is. You can see those lamellae and osteocytes. It's the same thing. They're just not arranged in osteons. They're still there, though. So here you can pause the video, go back and answer the questions. Let's talk about how bones grow. They grow in 2 main ways. One's called oppositional bone growth. Oppositional bone growth is where the bone is increasing in diameter. So it doesn't form original bones. This is when you're born and you're growing from an infant to an adult, right? The osteogenic cells will differentiate into osteoblasts, and the osteoblasts are basically forming and secreting new bone matrix and developing into osteocytes themselves. This happens under the periosteum. It's basically adding more rings to the tree trunk, so to speak, adding more circumferential lamella. The osteoblasts will then become osteocytes once they're surrounded by that ossified tissue. The deeper lamellae can be recycled and replaced by the osteons, and osteoclasts will help remove and eat away the bone at the inner surfaces to allow that medullary cavity to grow as well. So here you see the process. This is all, again, happening under the periosteum. As these number of rings are being laid down, the bone will grow in diameter. So it just gets bigger here. You see the overall result. And again, the osteoclasts on the inside are hollowing out that inner cavity to make room for the red and yellow bone marrow. In an infant, same thing happening. So let's talk about the periosteum. We've mentioned that it's the outer covering, but let's talk about its overall function and composition. There's actually two layers to the periosteum. It has an outer fibrous layer. This is the thick, dense, irregular connective tissue. And then there's an inner cellular layer that is connecting and innervating the superficial bone. Its overall function is isolation. All of our coverings are for isolation and protection. It's also providing a route for vessels and nerves. As you saw, some of those vessels from the periosteum go into the superficial bone. And it actively participates in bone growth and repair, as we just saw by looking at oppositional bone growth. There's perforating fibers that are within our periosteum. They're basically collagen fibers that help grow. They have a very strong attachment. They help hold the bone together if it breaks. So in other words, the bone could break underneath, but those fibers still hold it together. And this is why bone repair can be rapid depending on the location of the break. So if the bone is broken or there's a thick layer of periosteum, that periosteum will basically hold the bone together enough so that the bone can just regrow. And that's where x-rays come into place, and they might look at it and they might have to move and manipulate the broken bone enough to get it to go back into place. But that's basically how it works. It's like a little layer of Velcro on the outside of the bone, kind of Velcroing onto that superficial layer of compact bone there. Perforating fibers holding it in place, allowing that entrance point for arteries and veins. The endosteum is an incomplete layer to the medullary cavity. So it's an inner covering, but it's not complete. It's kind of a patchwork covering. This is very active during bone growth and repair as well as remodeling. So as the bone is getting bigger or changing in shape, maybe from different stresses, the endosteum is there. It's covering the spongy bone, lining the central canal, has many osteogenic cells there. And where the layer is incomplete, the exposed matrix has osteoclasts and osteoblasts there, which will help form little pockets or deposit more calcium, again, depending on your body's needs. So you can pause the video and go back and review. So I said there were two main ways bones grow. One is appositional growth. The second is endochondral ossification. Endochondral ossification is how your bones were made when you were an infant, when you were an embryo, really. This is embryonic bone formation. So the initial skeleton of an embryo is made of hyaline cartilage. So that hyaline cartilage will gradually be replaced by bone through this process of endochondral ossification. It's basically using cartilage as a model. As the bones grow in diameter and length, the diameter growth will then involve the oppositional bone growth. So in endochondral ossification, you have to have your cartilage model first. The cartilage model will get bigger, and chondrocytes will get bigger as well. Then eventually the chondrocytes will begin to die off, and that will basically leave the cavity empty. And so blood vessels will grow around this cartilage model, and a perichondrium will begin to convert some of those superficial cells into osteoblasts. Now these osteoblasts will form a very superficial layer of bone, typically along the shaft of the cartilage. Then blood vessels will begin to go into the cartilage and enter a central region. This is typically where that nutrient artery and nutrient vein will be formed in later development, but this is called the primary ossification center. This is where fibroblasts will differentiate into osteoblasts, and now bone formation can spread throughout the shaft and down to both ends of the bone. The growth will continue along with remodeling, so it might be osteoclasts and osteoblasts working together to shape out the medullary cavity. but that osteotissue will thicken the shaft of the bone, and the cartilage near the epiphyses will be replaced by bone, and the bone grows in length as well as in diameter. So those capillaries and osteoblasts will migrate to the epiphyses, forming secondary ossification centers, and then the epiphyses will fill with spongy bone. And finally, the articular cartilage will be exposed at the joint cavity. So here you see the whole process. You have this enlarging chondrocytes within this hyaline cartilage, and the periosteum forming on the outside, getting lots of nutrients. Those nutrients now coming in to the center area where the chondrocytes had been calcified. And this medullary cavity continues to enlarge. You can imagine the action of those osteocytes in that area. And then the blood vessels come into the epiphyses and start hollowing out that area as well. And now you're just left with a thin layer of articular cartilage, lots of spongy bone. You can see the epiphyseal line that was the boundary between the diaphysis and epiphysis, and again, that medullary cavity that was hollowed out during development. This is the whole process in steps. If you like to quiz yourself, it's probably good sequence of slides to do that. Finally, the bone grows in length at the epiphyseal cartilage, and the chondrocytes will produce more cartilage. The osteoblast will eventually replace the cartilage with bone on that diaphysis side, and the epiphyses are basically pushed away, and continued growth of the bones. So you have the chondrocytes at the epiphyseal side will continue to enlarge, the chondrocytes degenerate, and osteoblasts continue to migrate up, basically replacing the cartilage with bone. Bone growth continues through puberty. Hormones will stimulate increased bone growth. The epiphyseal cartilage is replaced, and eventually the epiphyseal cartilage becomes the epiphyseal line. In adults, this is what we call the growth plate. So it's just that boundary between the epiphyses and the diaphysis. And we eventually call it the metaphysis, but that epiphyseal line is where that last little remaining piece of cartilage that you held on to until you were done growing, in your late teens, early 20s. So here are 3 questions. You can go back and answer them if you pause the video. Let's talk about another form of ossification, intramembranous ossification. This is where bones can grow from a non-cartilage model. We call it an intramembranous ossification. This is when mesenchymal stem cells, remember mesenchymal stem cells are kind of all over the place in our body, they will differentiate into osteoblasts. And this is typically done within a fibrous connective tissue layer. So it usually occurs in deeper layers of the dermis. They're called dermal bones or membrane bones. Examples of these include some of the roof bones of our skull, some of those inner bones in there, our jawbone, our collarbone, and our patella, our sesamoid bone, all formed through intramembranous ossification. In other words, there was no cartilage there. It just grew from the connective tissue lining because the mesenchymal stem cells differentiated into osteoblasts. So there is an ossification center, just like an endochondral ossification. Those mesenchymal cells will secrete a matrix to differentiate into osteoblast. The matrix becomes mineralized, so ossification centers are forming, and then the bone grows out in little small struts called spicules, just these little tiny like radiations from this ossification center, and the osteoblasts will become trapped in pockets to become osteocytes, just like in oppositional bone growth, and the mesenchymal cells will produce more osteoblasts. Blood vessels come into the area. Those bone spicules start meeting and fusing and getting bigger and stronger, and the continuous deposition of bone by osteoblasts will result in a spongy bone with interwoven blood vessels. Then there's remodeling that will occur to produce the osteons of the compact bone. Connective tissue forms the periosteum, and the osteoblast will remain as that cellular layer of the periosteum. So again, here you have just a huge network of mesenchymal cells, blood vessels coming in, spicules starting to form, and now the blood vessels become trapped within a bone matrix, and the osteocytes are trapped within lacuna, and eventually the blood vessels become trapped in that ossified tissue. The whole sequence of it all. So intramembranous ossification happens during development. It typically begins during the 8th week of embryonic development. You can actually see the ossification centers forming and progressing even at 10 weeks, and at 16 weeks, most of the bones of an adult skeleton can be identified. Kind of cool. This is a 10-week-old fetus or baby, depending on what you would like to call it. But you can see those ossification centers of these bones being formed. You can see the little arm bones being formed, the scapula, the ribs, the legs, the hips. Super cool. Feet bones, etc. And here at 16 weeks, you can see all the skull bones forming. And again, the ossification centers, intramembranous ossification centers, were being laid down as early as 10 weeks in development. Super cool and kind of creepy at the same time. Same pictures. Okay, 3 questions there. You can pause the video, go back and review. Let's talk about some clinical things that can happen in bone anatomy and physiology. There are disorders that are caused shortened bones, like pituitary growth failure. This would be where growth hormone just isn't produced in high enough quantities. Growth hormone isn't just about growing, it's also about metabolism. So this can result in epiphyseal cartilage not being formed enough, abnormally short bones. It's very rare because typically this is detected and synthetic hormone can be administered. This would be an example of pituitary dwarfism. There's also achondroplasia, which is different from pituitary dwarfism. Achondroplasia is where the actual epiphyseal cartilage grows very, very slowly, and it's replaced by bone early in life. So in other words, the bones just don't have time to grow long enough. So you get very short, stocky limbs, but a trunk of normal size. Does not affect sexual and mental development at all. And this would be your typical little people in achondroplasia. There's also Marfan syndrome. This is kind of the opposite. This is an inherited metabolic condition. This is where excessive cartilage forms at those epiphyseal cartilages. So you get a very tall person with very long, slender limbs. It typically affects your collagen. So these people tend to be double jointed, be very flexible, have huge range of motion, and will also have cardiovascular problems because of the blood supply issues to their very long bones. There's also gigantism. Gigantism will cause lengthened bones. This is from an overproduction of growth hormone. So this is where people can get very, very tall. Typically, puberty is often delayed in people that have extra growth hormone. Can be caused by a tumor on the pituitary gland. It can be treated with surgery, radiation, medications to suppress the growth hormone. Like this fella here, obviously very tall. There's also acromegaly. Acromegaly is a little different. This is where the overproduction of growth hormone happens after the epiphyseal plates close. So after puberty, growth hormone continues to come out or be secreted, and so your bones are getting thicker instead of longer. And this typically affects joints of bones of the hands, the jaws, the face. It can also alter soft tissue structures. So this guy here, you can see his very strong jawline because of acromegaly. There's also FOP, fibrodysplasia ossificans progressiva. This is a gene mutation that causes bone deposition around skeletal muscles. So bones will develop in unusual places. These could be called heterotopic or ectopic bones. There's no treatment for this. Patients don't live very long because, again, bones are growing where they don't belong, in your thoracic cavity, in your skull, in your abdomen, and this can be very devastating. You can imagine the amount of pain someone would have living with all of these extra bones, basically immobilizing them. Very sad. There's also club foot, congenital talipes equinovarus. This is an inherited developmental abnormality. 2 in 1,000 births will have it, so it's fairly common. More common in boys than in girls. It could affect one or both feet. Usually it's a couple bones involved, including the tibia and the foot and bones of the ankle. The severity can be mild to severe. Typically, abnormal muscle development can result and your feet have to be kind of rerouted and repositioned. So you may have to wear braces. And clubfoot is typically where the feet are just inverted a little too much. So when you have a newborn, their legs are bowed anyways, but even after a few months, you can tell that their feet are just a little too turned, a little too inverted. So wearing braces to help re-secure them so that they can hold their own body weight. That would be clubfoot. And now newborns, again, they typically do have a little bit more flexibility in their joints. So sometimes you may look at a newborn and say, ooh, their feet are turned in. But this clubfoot is much more pronounced than in a typical newborn. So you can pause the video, go back and answer those 3 questions. Let's talk about the physiology of long bones a little bit here. So a whole new set of objectives for us. Let's talk about how bones serve as mineral reserves. Bones act as mineral reserves in the fact that many inorganic ions are needed for our overall osmotic balance in our body. We need them for vital processes in physiology. Our bone is not just made of calcium. There's other inorganic and organic components that our bodies need. So again, the majority of it is collagen in terms of protein or the organic components, but the inorganic components are hugely important. The majority of it being calcium, but again, other things are there. So let's talk about other things that are in our bones. As I mentioned, potassium, sodium, magnesium, carbonate, phosphate, all contained in our bones. And again, our bones contain 99% of the body's calcium, 35% of the body's sodium, 50% of the body's magnesium, 80% of the carbonate, and 99% of the phosphate. So they're super important, not just for calcium. So let's talk about calcium first. We'll talk about the other things. Again, it's the most abundant mineral in the body. 2 to 4 pounds of your body is just calcium. Kind of cool. The majority of it's in our skeleton. As we said, there's a variety of physiological functions. As we move through A&P 1 and 2, you're going to be hit in the head over and over again with calcium. So just kind of keep note. It's one of those common themes as we go through. You'll see calcium over and over and over again. We need it for blood coagulation and nerve generation, muscle contraction, etc. And typically normal fluctuations are around 10% in our blood. So we want to keep it very, very stable in our body. So we have to maintain calcium levels in our body. There are a couple ways this is maintained. Our intestines, right? Our intestines are responsible for absorbing calcium and phosphate through hormone control. Our bones will control calcium levels as well because of the osteoclast and osteoblast activity. Osteoclast releasing calcium into the blood, osteoblast taking calcium from the blood and saving it for later by depositing it on the bone matrix. Our kidneys are also responsible because our kidneys will help secrete calcium into our urine if we have too much, and that's all controlled through hormones. So let's talk about, this is just a visual here, let's talk about some of, you can pause the video, go back and answer these questions. That one popped up on me. Let's talk about these hormones. Parathyroid hormone, or PTH. Parathyroid hormone comes from the parathyroid glands. It's secreted from the parathyroid glands in response to information coming in from the bones, the intestines, and the kidneys. So there's all these feedback loops happening. And our bones, osteoclasts, are going to respond to parathyroid hormone by releasing calcium into the blood. The intestines will respond to parathyroid hormone by bringing in more calcium. The kidneys are going to respond to parathyroid hormone because they're going to release calcitriol to bring about calcium reabsorption in the kidneys. In other words, secrete less calcium. Hold on to it. Here's a nice visual for you, for all you visual people. I'm a huge graphic organizer maker. I wish I could teach this class to you in person so I could show you all of the fun things I like to draw. Parathyroid hormone here is going to activate osteoblasts and increase calcium absorption and increase calcium reabsorption from the kidneys by stimulating our intestines, as well as pulling it out of the urine and putting it back into our blood. Calcitonin does the opposite. Calcitonin is going to decrease blood calcium levels. Calcitonin is secreted from C cells that are in the thyroid. it is going to activate our osteoclasts. It's going to inhibit osteoclasts. Sorry, it's going to activate osteoblasts and inhibit osteoclasts. There we go. Calcium is going to be deposited instead of released. In the intestines, calcium absorption is going to be decreased. And in the kidneys, calcitriol and will not be released, and calcium reabsorption will not occur. Calcium will be secreted in the urine. Here you see the same picture, but for our calcitonin coming from the thyroid instead of the parathyroid, our bones are going to be building instead of breaking. Our intestines are not going to absorb as much calcium, and our kidneys are not going to reabsorb as much calcium. It's going to excrete more calcium. So overall result is a decrease in blood calcium levels. So as our skeleton acts as this calcium reserve, it's the major factor in calcium homeostasis. It has a direct effect on the shape and the strength of the bones. Release of calcium in the blood will weaken the bones, and too much calcium will strengthen our bones. So our bones kind of act as this buffer regulating calcium balance in our body. You can pause the video here and go back and answer these 3 questions. Let's talk about how bones break. Bones can crack or break due to extreme mechanical stress. They can heal as long as the periosteum and endosteum are still viable, and repair happens in 4 main steps. There's first something called a fracture hematoma. This happens within several hours of the break. It's basically a large clot that's closing off those vessels that are leaving the injury. Then a callus formation comes about. There's an internal and an external callus. This can take several hours to several days, depending on how bad the break is. The internal callus is the network of spongy bone on the inner edge of the fracture. The external callus is the external fracture. It's basically stabilizing the outside area of the bone. So spongy bone formation is basically happening as the cartilage is replaced by bone cells. So the callus is basically a temporary structure that's formed kind of like a little lid while everything else is happening underneath. So the bone fragments and the dead bone are removed, and the end fracture can be held in, the ends of the fracture can be held in place. So everything can be stabilized. Compact bone is going to form. Basically, that spongy bone is replaced by compact bone, and remodeling over time will remove all the evidence of the fracture. Although if you have ever broken a bone, like I broke my radius last year, about a year ago, I can still feel extra bumps on my wrist here. And that is the remnants of that remodeling. My bone's still undergoing remodeling from that. I also broke my humerus last year. That is a whole nother story, because that's all kinds of funky. Don't ever break your shoulder. You'll never heal. So here's just a quick overview of the whole process. Here you have a fracture hematoma forming from this broken humerus. And the fracture hematoma, again, is just a temporary blood clot, internal callus, external callus. Again, notice that the periosteum is still intact and still in place. That's super important. If the periosteum is damaged, this whole sequence is going to take way longer and might not even be possible without the aid of surgery. So as this process continues, all of our little bone cells, our osteoprogenitor cells that are still around, are going to continue to ossify and calcify tissue here. Blood vessels grow back together, and eventually you may still have a bump on your arm, and that process of remodeling will occur until all of this is kind of shaved down over time and your bone returns to normal. So there are several categories of bone fractures. They can be closed or simple, where there's just an internal break, there's no break in the skin. You can only see it on x-rays. Or it can be compound or open. This is where the bone's actually coming through your skin, much more damage, because once it's through your skin, you're through your first line of defense, right? Much more possible to not control the bleeding and to get infection. Transverse fractures are across the long axis. Spiral fractures are usually from twisting along the length of the bone. Displaced fractures would be where the bones are misaligned and they might have to be adjusted. Compression fractures, typically on your vertebrae from stress or osteoporosis. A green stick fracture is where just one side of the bone is broken, so the other side is kind of bent a little bit. This is typically in children where their bones have not ossified all the way. A comminuted fracture is where there's several fragments that were produced. That's what I had on my shoulder, really nasty. There's also epiphyseal fractures. This is where that epiphyseal line is just broken off. This is where that bone matrix is calcifying, so it can be healed properly and have no effect on growth, or it could affect growth depending on the age. A Pott's fracture is one that's specific to the ankle. A Cole's fracture is a break in the distal radius. That's what I had on my wrist. It's a Cole's fracture. And here you see all of these x-rays of a transverse, see that kind of just across, or a twisting or a spiral fracture. It's across and down. A displaced, this is totally misaligned. This looks like an ulna here. Compression fracture on our vertebrae. A green stick fracture just on one side of the long bone. A comminuted, this femur looks completely fractured here. This is the distal femur. This is an epiphyseal fracture. You can see this whole epiphyseal plate is just misaligned with the rest of the bone. The Pott's fracture on the lateral side of, it would be lateral side of the ankle, and the Cole's fracture on the distal end of the radius. You can pause the video here, go back and answer the questions, and this concludes chapter 6. Let me know what questions you have. Hopefully we'll have lots of time to talk about it in lab. And let me stop recording. See ya.